Hello and welcome to Learning EMG. In this video series, we're going to review the clinical and electrodiagnostic findings of the most common neuromuscular disorders. If you find our channel informative and helpful, please do subscribe and do not forget to hit the bell icon to be the first to watch our videos. In this video, we're going to review the anterior interosseus nerve lesions. Let's dive in. The branching anatomy of the median nerve is shown in the figure 1-8 of the book. The anterior interosseous nerve, or AIN, is a pure motor branch of the median that innervates three muscles in the forearm. First, the flexor pollicis longus, or FPL, that flexes the distal phalange of the thumb. Second, the flexor digitorum profundus to the index and middle finger, that flexes the distal phalanges of these two fingers. And finally, the pronator quadratus that pronates the distal forearm. Injury to the AIN can cause weakness of the FPL, the FDP to the index and middle fingers, and pronator quadratus muscle, without any sensory changes, because as I mentioned before, the AIN is a pure motor branch and it supplies no cutaneous innervation to the skin of the hand or forearm. Patients with AIN injury most commonly present with clumsiness in fine activities of the hand and loss of dexterity. They typically fail to make a circular OK sign because of the weakness of the FPL, the flexor of the distal phalange of the thumb, and weakness of the FDP, the flexor of the distal phalange of the index finger. Instead, they may form a triangle by extending the thumb and index finger. This is shown in figure 1-9 of the book. For the same reason, the weakness of the FPL and FDP, patients are unable to perform a pincer grasp using the tips of the thumb and index finger. As an example, they have difficulty pinching a sheet of paper between the thumb and index finger. On physical examination, muscle weakness is limited to the FPL as it is shown in the figure 1-10 of the book, the FDP to the index and middle fingers as it is shown in the figure 1-11 of the book, and weakness of the pronator quadratus muscle as shown in the figure 1-12 of the book. Because AIN provides no cutaneous innervation to the skin of the hand or forearm, all sensory examinations are normal in patients with AIN injury. Now let's review the electrodiagnostic findings in patients with AIN injury. First, let's review the sensory nerve conduction studies. Again, because the AIN provides no cutaneous innervation, all sensory nerve conduction studies of the affected hand are expected to be normal in patients with AIN injury. For example, the snaps to the median nerve, the snaps to the ulnar nerve, and the snap to the radial nerve are totally normal. Now, regarding the motor nerve conduction study, there is only one abnormal CMAP in patients with AIN injury. The CMAP to the pronator quadratus muscle is expected to be abnormal in these patients. In axonal lesions of the AIN, the CMAP to the pronator quadratus may be low amplitude or absent, depending on the severity of the lesion. You can see the motor NCS technique for obtaining a CMAP from the pronator quadratus muscle in the figure 1-13 of the book. Now, in demyelinating lesions of the AIN, the CMAP to the pronator quadratus may show a prolonged motor latency and temporal dispersion that is consistent with focal demyelination of the anterior interosseous nerve in the forearm. Okay, now what are the normal CMAPs in patients with an AIN injury? Please remember that the CMAP to the abductor pollicis brevis is expected to be normal in patients with AIN injury. This is because the motor branch to the abductor pollicis brevis arises from the main trunk of the median nerve in distal forearm. This is not going through the AIN. So please remember that in patients with AIN injury, the median CMAP to the abductor pollicis brevis is expected to be normal. This is an important point to consider. Now, what are other normal CMAPs in patients with AIN? As we may expect, the CMAP to the ulnar nerve, the CMAP to the ADM, the CMAP to the FDR are expected to be normal in these patients. Also, the CMAP to the radial nerve, for example, the CMAP to the extensor indicis is expected to be normal in patients with pure AIN injury. Now, finally, we're going to review the needle EMG findings in patients with an AIN injury. The muscles with abnormal EMG studies are expected to be the FPL, the FTP to the index and middle fingers, and the pronator quadratus. These muscles may show neurogenic abnormalities in patients with axonal lesions of the AIN. These muscles may show reduced recruitment in patients with pure demyelinating lesions of this nerve. And regarding the muscles with normal EMG studies, please remember that EMG of other median innervated muscles, for example, the abductor pollicis brevis, the FCR, the pronator tres, and the FDS are all expected to be normal in patients with AIN injury because these muscles receive their motor innervation from the main trunk of the median nerve. As you may expect, other muscles in the forearm that are innervated by the ulnar or radial nerve are expected to be normal in these patients too. Okay, this video will review the clinical and electrodiagnostic findings of an AIN injury. We have gathered a summary of the clinical and electrodiagnostic findings of the most common neuromuscular disorders in this book entitled Summary of Electrodiagnostic Medicine. This book is available on Amazon.com. You can hit the link below in the description to see the book page on Amazon website. Also, if you are interested in studying real cases related to AIN injury, you will find our other book titled Case Studies in Electrodiagnostic Medicine helpful. In this book, we have included a real case of AIN injury and we have discussed the clinical and electrodiagnostic approaches to these patients. Hope to see you soon with another summary video. Take care and bye.